Welcome to read an article, learn, search, and get updated. From the Journal of Dental Research, we choose this article for you. How to reduce aerosolized microbes in dental practice. A systemic review with network meta-analysis of randomized controlled trials. How to reduce microbial load in aerosolized compounds in dental practice. Tempered chlorhexidine 0.2% with non-active control mouse rinse before ultrasonic scaling to reduce bacterial load at 47 degrees. In COVID-19 pandemic, it's important to evaluate aerosolized microbes and the viruses. The working environment of dentists leaves them exposed to certain hazards and risks. Airborne particulates produced with high rotary instrumentation during or after the performance of the composites and restorations. They are linked to potentially infectious bacteria, viruses, fungal pathogens, or other microorganisms that reside in the oral cavity of the patients. Aerosolized microorganisms, including potentially airborne pathogens, may come as a result of the active performance of high-powered handpiece used during standard dental procedures, tooth grinding for restorations, material grinding, composite removal after orthodontic debonding, and attachment grinding after aligner treatment. Routine oral prophylaxis with the high-speed ultrasonic scalers are responsible for increasing dynamic for respiratory-related contamination within dental practice environment and across the staff. The potentially pathogenic capacity of aerosols produced in dentistry depends on the combination of in-surface compressed air and water spray, with tooth and material debris, plaque, blood, calculus, and saliva mixtures, all combined to help the dynamic of this airborne disease. Role of microorganisms being present with the dental unit water lines and their potential to mix up with oral cavity, for example blood and saliva. Aerosols may set a risk for disease transmission and cross-contamination within the dental clinic environment. However, this is largely dependent on patients' pathogenic potential and the positivity for induction of the airborne disease. Solution and interventions reduce patient and professional related aerosol induced contamination, mainly directed towards the use of the antiseptic agents as pre-procedural mouthwash rinse solutions. The use of tempered chlorhexidine 0.2 mouse rinse comes first in the ranking in this study, then the use of ozone standard chlorhexidine 0.2 only or 0.12. We can use also bovidin iodine and chlorine dioxide. Use of alternatives as high volume evacuators, in-service instrumentation coolant agents, antiseptic agent directly applied to dental unit water lines. ADA Council in Scientific Affairs and ADA Council in Dental Practice have included these recommendations. For infection control against spatter and droplet forming aerosols, we can use protective eyewear, high volume evacuator, appropriate positioning of the patients, and rubber dams were recognized as the foremost protection strategies. The bioaerosol stimulation happens mostly due to oral prophylaxis measures in office through ultrasonic scaling and enamel cleanup practices after orthodontic fixed appliance debonding with high-speed instrumentation. Notes in this study: the tempered chlorhexidine 0.2% at 47 degrees was ranked as the most effective in achieving reduced bacterial load after the use of ultrasonic scaling in dental practice. With regard to overall percentage, surface under the cumulative ranking curve values for effectiveness. The small particles of the pathogens have been considered respiratory system triggering process, thus making their way deeply within the lungs. Aforementioned concerns are augmented by the latest awareness of microbial spread, air suspension, and stability in aerosols and on surfaces. An up-to-date report based on experimentally induced simulations have suggested that stability kinetics of severe acute respiratory syndrome related coronaviruses may leave them viable in aerosols for at least 3 hours, even in reduced infectious titer. The presence and detectability of COVID-19 in the saliva of the infected patients impose an additional risk for air suspension after an aerosol generating dental procedure. The focus of this review is on ultrasonic scaling, which is responsible for generating aerosolized microbes in a massive way. Chlorhexidine in dentistry has been well reported mainly as a large-scale disinfectant toward the management of gingival inflammation, plaque control, and mechanical therapy in patients with chronic periodontitis. However, adverse effects of chlorhexidine are taste disturbance, mucosal ulceration, burning sensation, and oral mucosa soreness. So we modified the concentration and the temperature as a safety consideration for preventing any bulbal or mucosal adverse effect. Tempered solution revealed an increased efficacy against microbial plaque accumulation and increased potential for bacterial counts elimination. Alternative effects and action of povidone, iodine, ozone, and chlorine dioxide related to certain pathogens types due to their oxidation potential in reaction with virus cell structure. Bacterial species study of microbial complexes revealed an increased spread of the orange complex in aerosols produced after ultrasonic scalar use, which represented by Fusobacterium genus that was higher in the absence of any active pre-procedural mouse rinse intervention. Fusobacterium nucleatum has been involved in the initiation and progression of periodontitis, and it inhibits gingival fibroblast, gingiva-derived mesenchymal cell proliferation, also inhibit generation of intracellular active oxygen species, promote cellular apoptosis. Also, Fusobacterium nucleatum infection has been linked to other pathologic ophthalmic and respiratory conditions. The role of dental unit waterlines in the formation of contagious spatter compounds can be treated by installing water filter, shock disinfection of hydrogen peroxide with concentrations ranging from 3% to 6% volume per volume chlorhexidine, and the specially designed biofilm removal system have been proposed. Conclusions. The findings of the present network meta-analysis suggest the use of pre-procedural mouse rinse with preferably tempered chlorhexidine as the most effective strategy for the reduction of aerosol-related bacterial load in dental practice. In addition, in temporal conditions caused by seasonal epidemics of other forms of pathogens, mostly represented by oxidative stress, vulnerable viruses, substitute intervention strategies such as povidone iodine might be considered as a viable solution. We should do more research about disinfectant agents to be used as a mouthwash rinses.